Okay, good morning, everyone. Welcome to the second talk of this week's patient safety learning. We're joined this morning by Justina Rutkowski. She's a SPR at Queen's Romford with an interest in patient safety, and she'll be presenting today our lightning learning on effective communication. So Justina, whenever you're ready.
Okay. Hi there. Thank you for the introduction. So this is the lightning round, so it should be 20 minutes. So the topic today is tools for effective communication. So as per the RCPCH progress, I'll be covering 3 outcomes, outcome 2, 6, and 7, focusing on communication, team working, as well as patient safety. In terms of the aim of this presentation, it's to provide pediatric trainees with a toolkit to aid in effective and safe communication. The main objectives are to actually define what effective communication means, look at the challenges of it, as well as discover the tools and strategies that can be used to provide a safe communication, and as well as apply those tools to various pediatric cases. So what is communication? Essentially, it's a transfer of information from a sender to a receiver. It includes the ability to ask questions, to seek clarification, acknowledge that the message was received and understood. Effective communication in itself is shared understanding between the sender and the receiver. And when we're looking at communication, we also have to take into consideration 2 things. Who am I speaking with? Whether it's a colleague on the same educational level, or whether it's a junior nurse that has just started her training, and how I'm communicating, whether it's verbal or nonverbal. Nonverbal being body language or even written language, such as writing a letter. So the principles of communication. So if we look to the left, this box here, effective communication means that, the principles involve a complete, clear, brief, and timely. And so what does that mean? When we speak to somebody, we need to, give a complete explanation, including the essential bits. That's what complete. It's clear, that it's understandable to various people. It's brief, it gets to the point, and it's timely. It's given at an appropriate time. So if we think about nonverbal communication, such as prescribing buccal midazolam, for example. So you've written buccal midazolam 5 milligrams, a buccal OD. And you've given this prescription to the parents. So it's complete in the sense that you have the drug name, the dose, the way that it's given buccally. It's clearly written, it's brief, it gets to the point, and it's given timely, as in it's given prior to the child being sent home to the parents. There's various challenges in terms of communication. So I've done this word cloud here. And if anybody can come up with various challenges, you could just put in the text box. What are your challenges with communication on a regular basis? So you can just shoot out some things. Anybody? Everybody's being shy? So what kind of struggles or challenges do you find with communicating on a regular basis with your colleagues? Yes, not enough time seems to be one of those. Anybody else? Prior knowledge, language barriers, that's correct. Yeah, so looking at this word cloud, the ones that I've come up with: language barrier, personality. So sometimes somebody might have a stronger personality type, over being stressed out, increased workload, the shift changes going from morning to evening, and so forth, and just conflicts in general. So now the next question is, so what communication tools are you familiar with? So in the audience, can you just name any communication tools that you've come across or you've actively used in your day-to-day practice? Yes, I'm seeing SBAR, ICE. Yes, that's a different one, Christina. Okay. Okay, so I'll start off with the most common one, which is SBAR. Um, so anybody can essentially use this thing called SBAR. It's used in everyday settings between nurses to nurses, nurses to doctors, ambulance crew to doctors, and so forth. And it can be used in various settings, such as a ward to A&E, or a transfer of a patient to a tertiary center from a district hospital. So S, just kind of an overview. So S is it describes the specific situations. This is really the point that highlights whether the child is ill or stable, as well as just identifiers. So what is the name of the patient, the location, and the age. The background gives a good detail of the presenting history. So whether the child came in with 3-day history of cough and coryzal, on a background of being having cerebral palsy, or complex history. And then assessment is your A to C or A to D assessment, your OBS, what investigations have been taken, and what your kind of working diagnosis is. And then recommendations, what do you recommend in terms of moving forward with this patient? What are your suggestions, or what do you seek assistance for? So I'm going to give 2 examples, one in the general peds world and another one in neonatal practice. So so you have an SHO that is A&E. It needs to hand over to the registrar in the pediatric ward a child that needs admission for a urinary tract infection. So S, you have to, first S, we have a stable 5-year-old boy in the pediatric A&E. B is the background, so it's a 2-day history of increased temperatures with rigors, a left-sided flank pain, and a 1-day history of non-bilious vomiting on a background of otherwise being healthy. And then A is your assessment, so this is your A to C assessment. So initially was tachycardic and parexial. Settled after paracetamol, so the OBS at the moment are stable. On examination, the child has a bit of mild dehydration characterized by dry lips, but cap refill time is less than 2 seconds and has decreased urine output. Has positive costal vertebral angle tenderness on the left side. We did full bloods. FBC shows that the white cells are elevated to 30 with neutrophils of 25 and a high CRP of 160. A urine dip was completed and it showed +2 ketones and nitrates and leukocytes positive. So my working diagnosis here would be left-sided upper pyelonephritis with moderate dehydration. So my recommendation to this registrar would that this child warrants admission given the history of the vomiting, severe blood parameters. I would start the child on IV antibiotics, chase the urine culture, and do an ultrasound in the morning time. So that's the first example. And then looking into in neonates, so a recurring thing is, you're an SHO working in the neonatal department in the district hospital, and you're holding the labor bleep. You get a call from the midwife saying you need to urgently see this child. It's 2 hours of life, and it has this increased worker breathing. So you quickly go see the child. And you see that, yeah, in fact, it does increase worker breathing with low saturations, and you know that you need to contact your registrar very quickly. So you use SBAR in preparation to speak to your registrar. So once again, starting with S. So this, hello, this, my name is so forth. I'm the SHO on call. I have a sick baby. 2 hours of age with increased worker breathing, requiring oxygen in the postnatal ward. The child is, in my opinion, sick. And then the background, it was a term baby. Only risk factor for sepsis was PROM, normal scans, normal serology, not, normal vaginal delivery with normal CTG, and good APGARs upon delivery. And then my assessment. So A, vitals are, I've counted the respiratory rate is 90, saturations are 80, heart rate is high, 160, and the temperature, the child actually spiked is 38.5, and has signs of increased worker breathing characterized by nasal flaring, grunting, intercostal recessions. I've placed the oxygen mask on the child, and the saturations improved from 80 to 100 on oxygen requirement of 30%. So my differential diagnosis in this case would be suspected sepsis or possibly congenital pneumonia. My recommendations to this registrar would be it needs admission to NICU for oxygen support, as well as a partial septic screen, and to keep no by mouth and start on IV fluids at 60 mLs per kg until the worker breathing settles, and obviously needs also a chest x-ray. So that's just, the ins and outs of SBAR. The next one is something called Callout. So basically Callout is used in any kind of critical emergency situation. It just lets the team members anticipate the next steps. So it's important to direct responsibility to specific individuals carrying out the task. So basically, imagine being in a recess situation and the call out. So the leader of the recess would say A, and then someone would say airways patent, B, good air entry bilateral, so the breathing is fine, C, circulation cap refill time is less than 2 seconds. So it's just a matter of calling it out and making the whole team aware, and that's what the principles of this is. The next one is Checkback. So this is essentially a closed loop communication. So basically it's the sender initiates the message, the receiver accepts the message and provides feedback, and then the sender double checks that, ensures that the message was received. So if in the recess you have a 5-year-old that is started to seize at 3 minutes, and you anticipate that this child might continue to seize for up to 5 minutes, and you want to get buccal you just shut to the nurse and say, please prepare buccal 5 milligrams. She goes and grabs it and says, here's buccal, and then by 5 minutes, if the seizure is present, ongoing buccal is given, and then the sender says, thank you. Okay, and the next concept is mutual support. So it's critical for team performance, and to facilitate mutual support, it involves essentially 3 principles. One is to assist each other. So, if someone is struggling at performing a task, to be able to help out and to acknowledge that this person is struggling and to offer that help. 2 is to provide feedback, positive and negative, to in the context of it being respectful feedback for the overall goal of improving. And then 3 is exert behavior that would advocate for the patient's safety when it feels like it might be threatened. So mutual support in itself is the essence of teamwork. In the healthcare setting, when team members increase workload, may actually result in fatal consequences. So mutual support provides a safety net to help prevent errors, improve efficiency of work, and minimize strain by workload. And over time, we can see, that it will build trust and a good relationship among colleagues. So the main thing I'm going to focus is on this part, to advocate for the patients, to make sure that, patient safety is the primary goal. Okay. So the first kind of way that we advocate for patient safety is using Goose. anytime you have something that you're concerned about that you feel just seems a little bit off, you're not happy with the way that the patient is being managed, this is just an easy principle to follow. So the way you use it is just say, first state your concern, second state why you are uncomfortable. And so these are key words, and those I'm concerned or I'm uncomfortable really highlight uh, that there is an issue going on. And if still by this point the conflict is not resolved, then it's important to say the word safety, that there's an issue with safety here, and discuss why you have this concern about the safety. And if by then it hasn't made a difference, then really it would be important to escalate that concern to someone even higher than the person you've discussed with. So in terms of a case, I'll just give you an example. So you have an SHO, or you are an SHO working in a busy district hospital. You are asked to see Sarah, who's a 6-year-old known as Matic, who has come in because of progressively increased worker breathing for the last 1 day, on a background of having cough and coryzal with wheeze for the last 2 days. She's otherwise apraxial, has never had any HDU admissions. Her asthma is well controlled. She uses salbutamol just as a PRN aero chamber. So initially she presents, her vital signs are apraxial, heart rate is normal, is 95. Respiratory rate is 32, which is her upper limit would be 25. And she's saturating well at 95%. So on examination, she is speaking in full sentences, so no sign of dyspnea. She has signs of increased worker breathing characterized by tracheal tug and intercostal recessions. You auscultate her chest and you hear that there's bilateral wheeze on expiration. So you decide to give her back-to-back nebs and prednisolone. And then you review her in about 30 minutes time. And when you review her, you find that her vitals have not changed. Her respiratory rate is still high. It's at 32, and she's saturating at 95. And you're just not happy with her. So you think, okay, best to just give the registrar a call. So you call him up and you say, I have a 6-year-old girl known as Matic, has a moderate increased worker breathing. I've given her back-to-back nebs and one off pred. And I'm concerned, so here, keyword here, I'm concerned because she hasn't improved post initial back-to-back nebs. And then the busy registrar interrupts you and says, well, just give another salbutamol neb. And then this is when you would, if you're still concerned, then this is your opportunity to say, I'm uncomfortable with this plan and like you to urgently review this girl. I think she might need a second line of management, such as magnesium sulfate. And then the registrar will acknowledge that and hopefully say, okay, I'll come immediately to review. And then the other rule to use when you're concerned is something called the 2-challenge rule. So it's another tool to facilitate team members to speak up. So 2-challenge rule is a way to keep team members from, letting them communicate their thoughts and decisions. And it's a goal. It's basically a goal is to create a teamwork culture where team members respectfully challenge one another when plans seem a little bit unclear or there's some level of concern. So it's important to voice your concerns by advocating and asserting your statements at least 2 times if the initial assertion is ignored. And that's the why it's called the 2-challenge rule. So the important thing here is that the first challenge should be in a form of a question. Okay, so first time you ask it in the form of a question, and then the second challenge should be in showing some kind of level of support for your concern. So whether that's literature, guidelines, and so forth. So at the end of the day, remember that it's all about advocating for what is in the best interest of the child, the patient.
Do you have an example of that one?
I'm going to go through that. So in terms of in my example, so the case would be, so a 7-year-old male has come to the A&E with a 1 month history of weight loss and polyuria and polydipsia. Capillary guesses that he's metabolic acidosis, so his pH is 7.1 and bicarb is 14.0, with a very, very high sugar of 26, and his urine shows plus ketones. So he has a initial diagnosis of DKA. And then, as per the guidelines for DK, he receives a one-off 10 ml per kg bolus, followed by maintenance fluids. And at 1 hour starting the fluids, the registrar prescribes a higher dose of insulin. So normally the insulin can be given at 0.05 to 0.1 units per kg. So this new ST4 decides he'll just go with a higher dose of insulin. And the nurse in charge looks at that prescription as it's about time to start giving the insulin drip, and says, most of the time, why have you prescribed this? So this is the question, the first part. And then he just said, oh, I'm not sure, I just prescribed it just because. So not really a clear explanation for that. And then the nurse in charge goes and grabs the CATS guideline or whatever hospital guideline you have for DKA, and then shows the registrar. In most cases, the first presentation of a DKA is started with 0.05 units per kg of insulin. So why don't we try this? And then she shows him the CATS guidelines for it, and he reads through it, and then he changes his prescription. So it's just, and it's sometimes with a 2-challenge rule, it can, the different attempts can be made by different team members. It doesn't have to be the same person escalating concerns. And then, so that's my whole presentation. And the take-home messages. So general principles, we've discussed the effective, what entails effective communication, what the challenges of it are, as well as what, the main 3 communication tools that I found most helpful is SBAR, Callout, or the closed loop communication. And then when concern arises, to use CUS or the 2-rule challenge. Those are my references, and thank you. Any questions?
Thank you, Justina. That's a really concise presentation, and thank you for using examples, because I think that really helps to embed it in what we understand as day-to-day practice. Have you noticed that using these tools helps to increase the mental or improve the mental model, as in everybody tends to be on the same page as a result of it?
Yeah, I find that it just, you know what to expect, you know what to test, and there, because if it's well organized, then at least there's ability to ask to clarify if something isn't clear by going through, for SBAR. If something isn't clear in the first part of S or B, you can just say, can you clarify that again? There's room for that. So I think it's very useful.
Yeah, and I think with Checkback, especially in resus situations, it helps everyone understand what exactly has been given, because often the person who's leading may shout out several instructions in one go because there's a lot that needs to be done. And it's sometimes difficult to know which of those things has been actually done and which things are still taking time, or which things did people not pick up on. So with callback, we say, someone get me 5 milligrams of buccal midazolam, then the nurse will say, here you go, 5 milligrams of buccal midazolam going into the patient now. And then that way, then, like, that closed loop communication means that everyone knows that it has actually been done and not just vocalized. So I think, yes, you're right. It helps the kind of everyone understanding where exactly we are in the current situation and moving forwards. Yeah.
Does anybody else
have any questions?
Yeah.
No, I think you probably have said it all very concisely. But
Okay.
left any questions for anyone? thank you again for your time, and thank you for all the effort that you put into it.
Thank you very much. Thank you for listening.
All right, take care. Have a lovely day, everyone.